This conference will now be recorded.
Hi, everybody. Welcome. My name is Lauren Brands. I'm the Outreach Coordinator for the Laureate Eating Disorder Program. I'm so happy that you're here to join us today for our special webinar. Before we jump into what we're all here for, which is Hannah George's special webinar on Bridging the Gap, we're going to dive into some updates here at the Laureate Eating Disorder Program. So welcome. A couple of COVID-19 updates. As you all know, eating disorders continue to threaten the lives of patients despite this really challenging time in our world. And Laureate is a part of Oklahoma's largest and most trusted health system, St. Francis. And because we're under this umbrella of St. Francis, Laureate has access to internal COVID-19 screening and in-house lab services. So at this time, Laureate is accepting new admissions. If you have any questions about that, feel free to email me. I will have my email in the chat box. So who are we? I'm excited to announce that we are celebrating our 30th anniversary of the Laureate Eating Disorder Program. We are an individualized care, nature-focused campus that is highly individualized for women and girls from all over the world. 80% of our patients and families are from out of state. And we like to call it an intentionally small milieu. And we received mission-based care from passionate staff who believe in the not-for-profit mission. And we have close collaboration with the Laureate Institute for Brain Research, and so we get a lot of cutting-edge research from that brain research center. Our therapist to patient ratio is 1 to 3, and we love to accommodate patients of all cultural and religious backgrounds with extensive experience with women and girls of the Orthodox Jewish faith. So our levels of care. So we have acute inpatient stabilization, residential care, partial hospitalization, and outpatient care, which is available to boys and men. Our outpatient care services are telehealth at this time. Certificates, I know this is what you're all wondering about. The certificates of completion surveys will be emailed to attendees this afternoon. It's going to be from myself or our new referral rep, Corey. The handouts of the slide will be emailed to attendees after the presentations. I'm going to go ahead and just say the accreditation statement. This allows us to get CEU credit and CME credit as well. We have it approved for the CADC and the LADCs, which is St. Francis Health System, is an approved provider for continuing education programs for CADC and LADCs through the Oklahoma Board of Licensed Alcohol and Drug Counselors. For social work, these events have been approved by the Oklahoma State Board of Licensed Social Work for 1 hour Category 1 clinical, CEP number 2020007. And lastly, St. Francis Health System designates this live activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should only claim the credit commiserate with the extent of this participation in this activity. Thank you. I know that's an earful. Lastly, we have our required disclosures for our CME, which is for physicians and psychologists. This is specifically for this event, which is Bridging the Gap, identifying and addressing transition obstacles between inpatient and outpatient. This is by Hannah George, who is LMFT, on July 29th, 2020, and it's live stream. If you would like this copy for your own records, please feel free to email me, and I would love to send that to you. So without further ado, I am super excited to introduce a very dear friend of mine who is amazing. She is our speaker for today. Her name is Hannah George, and she is an LMFT. She's a therapist for the Laureate Eating Disorder Program for the adolescent side. I'm going to go ahead and read her intro. Hannah George was born and raised in Tulsa, Oklahoma, and she first joined the Laureate Eating Disorder Program in 2013 as a psychiatric technician, where she discovered a passion for assisting patients and families through the recovery process. She completed her Master of Arts in Christian Counseling with a marital and family therapy concentration at Oral Roberts University, then rejoined the Laureate Eating Disorder Treatment Team. Hannah appreciates her work with families and using relationships to help move patients forward. She utilizes a family system approach in her work with patients and advocates for patients to take an active role in the recovery process. Hannah, sorry, our phone is ringing. We're going to turn that on silent here in a second. Hannah also enjoys using creativity in therapy through experiential techniques. Without further ado, I'm super excited to introduce to you guys my friend Hannah George, and I'm going to pull up her PowerPoint right here. Okay, Miss Hannah. Okay, we're just gonna pull it up really quick. Okay, here you go, Miss Hannah.
Okay. Thank you, Lauren. Our marketing team is so fantastic. I always feel very deeply loved and supported by them. I feel like they're our biggest fan, and they're also you guys' biggest fan too in the outpatient world, because you all are the ones that are really continuing and carrying the bulk of this topic that we're talking about today of maintaining change after inpatient treatment. Looked like we had quite a few outpatient therapists and some dietitians who were joining today. Here's the things that I like to see in a webinar. I want something, first of all, that's going to give me tips to interact with my clients even today. So I'm going to be sharing a lot of stories. I'll have practical application throughout this webinar. And I hope that even this afternoon, as you're leaving this webinar and meeting with clients, that you're able to pull some of this information in. The second thing that I like in a webinar is I want to be growing too. That's why I like to be a therapist, is I like to learn and grow. I like to be pushed. And so I hope that as you listen to this information, that you're getting ideas for your own journey, that you feel that more empowered to maintain changes in your own life, because it can get so discouraging to want something to be different, make change for a while, and then feel like you're backsliding. This topic has become really interesting to me for two reasons. First of all, during the patient's time here, we're always assessing, they're making a lot of changes, will they be able to keep these changes when they go home? One of the groups that I run here that I really love is the relapse prevention group. So I'm always doing some research and trying to pull some new information on what home needs to look like to really be able to maintain change. The second reason why this topic is interesting is on a really personal level. So about a year ago, I have a very close friend who's been struggling with an alcohol addiction for some years, and she had reached rock bottom. And so she made the really difficult decision to seek out an inpatient rehab facility. And so she left her family. It was a really big financial decision to make because it cost a lot of money. She also had to put her job on hold, which was threatening whether she'd be able to go back and work at a job that she was really passionate about. But that's where she was. She was just rock bottom. She had to do something. I talked to this friend while she was in that treatment facility, and she was learning so much. It was like I was talking to my friend again, who I hadn't talked to in years since the addiction. She was changing, she was growing, she was being vulnerable. But then as she neared her transition home, I started to ask her about what that transition would look like. And she would say, you know, I really haven't talked in this treatment a lot about what it will look like at home. We don't really talk about that. We're more focused on working on skills here. And that just started to raise a red flag for me. I was really concerned about that because I've seen this play out for patients before, just how crucial that transition home is. This really dear friend ended up discharging from care and didn't have any outpatient appointments scheduled. She had been prescribed some medication that she didn't even have a psychiatrist to follow up with and to be monitoring the medication. She also, the team at this particular facility had not included family in their work. So she went home to a husband who continued to enable her drinking. So on a very personal level, I've seen what that's like for family and friends around loved ones when they see that huge change and shift being made in treatment, but then see somebody backslide once they get home. Okay, I'll just briefly cover these objectives so that you all know what to expect from this webinar. This presentation will provide a discussion of ways to prepare eating disorder patients for transition from inpatient to outpatient care. There is a lot of preparation involved with that. A review of potential challenges during this transition, tools to enhance growth opportunities within these challenges, because we know that even if something's difficult, it can provide a lot of growth. And then exploration of ways that eating disorder patients can maintain changes made in inpatient treatment once they are home. And that's where I'm going to spend the bulk of this webinar, is really talking about very practical ways that patients can maintain changes. Okay, preparation for transition from inpatient to outpatient care. For me, effective inpatient to outpatient transition begins with the end in mind. So that starts on the very first day, that first moment that I meet a new patient coming in and meet with their families. I'm already thinking about sending them home. That time comes so quickly. And so beginning with the end in mind, knowing that we are passing this person back home to their families, that really puts things into perspective. Effective treatment is also individualized. That's something that we really pride ourselves on, is having a small milieu and being able to individualize care so that it looks appropriate for the particular patient. So sometimes that includes weight restoration, other times it doesn't. Sometimes it includes addressing comorbid diagnoses, other times it doesn't. So for each person, this is going to look really different. I had a patient just the other day who was telling me, oh, you guys aren't individualizing this. I'm just a number. And I was like, au contraire, these are the things that we are addressing for you specifically in your treatment plan so that you can get home and stay home. As patients near their discharge dates, there's also this pulling away process from their inpatient support and reconnecting them back at home to their support system and their outpatient teams. This is a crucial shift that happens. So some of these patients come in, they've never really opened up before, they've not been vulnerable, and they feel that they're in a place where they're understood and they can connect to other people who are like them. That can get very comfortable and safe. And so as patients near their discharge dates, there is this pulling away and putting them back into the arms of their loved ones and their outpatient teams so that it's not such an abrupt shift. I had a patient a couple of months ago who I would come into work every morning and she would leave a little note under my door. It was there waiting for me. I knew exactly what to expect. And it always said, hey, can we check in about something? So that, I'm establishing rapport, really connecting with this patient. And so that was something that we did, was we generally had a check-in each day. But as we got close to her discharge date, I started writing my own response on her little sheet of paper that said, why don't we talk about this in group instead? Why don't you talk about this on phone calls with your family? And so I was redirecting her so that she was getting her support from other people than just me, because I don't go home with her. And she started to get the gist of that. And then her little notes under the door would just say things like, hey, hope you're having a good day. And she knew that she was to bring up things and be connecting with her family and with groups, which was a lot more uncomfortable for her. It can also be helpful to normalize the grief process. I noticed this trend with patients that sometimes when they get close to their discharge date, there's more acting out that happens. And I think that this is a sign of showing you're grieving. It's a sign of showing that you're really scared. And so not seeing that as a sign to step back, step up care, keep them longer, it's really them showing, hey, I'm scared, and helping to normalize that for them, that is a really scary process, and that it is normal for patients to have higher urges because of the fear and anxiety that they have about going home. These are just a couple of things I wanted to just throw out as ideas for you guys of things that we've had to change and adjust as COVID has really limited some of the things that we can do for transition. So we are doing virtual snacks and meals with family, opportunities for patients to not get checked at meal time. So that means that as they finish a meal, there's not staff going around to make sure that they've scraped. We're not checking their portion sizes. And then we're looking at their weight over time to see if it's dropping, if it's staying stable, and if they're doing what they need to do. We started some cooking exposure groups, which has been so fun and fascinating to see how they're responding as they are engaging with the food prep. We're also doing meal innings. So we're bringing food from outside restaurants in to our patients. So it's not just something that's safe provided by our chef here, it's something from the community. Lots of phone conversations with support systems at home and outpatient team, and then increasing family sessions as we're nearing the end of treatment. We know that there are so many challenges that come up as patients are transitioning from inpatient to outpatient care. There's this feeling of isolation and loneliness. Like I mentioned earlier, some of these patients have never felt like they've been able to connect with people before. I have patients who come in who just have this history of bad friendships and friendships where they felt a lot of rejection. So they're going back home to that environment and they can feel really lonely. There's decreased support and accountability. One patient came in, she left last week and she was saying, I'm so sad because I don't have a therapist that I can just pop in her office anytime I have a question. So they can feel that, they feel that loss. There's also unrealistic expectations about the recovery process. And we know that the recovery process is not linear. It is that also famous graph of like up and down and topsy-turvy. And that is normal. That is what they can expect, is that they don't go home and feel better and their whole lives are awesome. One client emailed me not too long ago and said, this is the weirdest thing. I got home and I woke up in the middle of the night with eating disorder thoughts. And I just responded, that's normal. Those thoughts don't just disappear because you've left treatment and your weight restored. Loss of structure. I think especially during this pandemic that we're facing, that there's things that are closed, kids aren't going back to school, and that sense of structure is really safe for this population. And then there's the environmental challenges, stressful situations at work or school. They may face loss or interpersonal conflict. And then of course, the global pandemic that is going on right now. Some more challenges, just the body changes. So if a patient has had a lot of weight restoration that they've done in treatment, then they go home with a new body, a body that they haven't been in for a long time. And so being patient with that, learning the new normal. Comments from family and friends, those are bound to happen. I had one patient who even had a comment from a pediatrician, and I can make fun of pediatricians. My husband happens to be one, but by golly, if they don't say things sometimes that just make us crazy. So this patient had gone to a pediatrician appointment, and the pediatrician said, oh, I see here that you've been in inpatient treatment, and I wanted, and so that must have been for bulimia or for binge eating, because she was someone who was maybe over what we would consider an average body size. And she was like, no, and actually very offended because she actually had been restricting and her diagnosis was anorexia. So just people can say things that are insensitive and can cause patients to want to take steps backwards. Of course, there's diet culture and social media, and then premature discharge. It's not uncommon within this population that someone would want to leave AMA, leave early, or maybe insurance cuts off before the treatment team and patient feel ready. Many of you all are familiar with the trans-theoretical model. So before we talk about how to maintain change, it's important to address where someone's at. Are they even ready to maintain change? So the trans-theoretical model, that's pre-contemplation where someone doesn't think there's a problem. One of my patients right now is in that stage for sure. She keeps saying, I don't even know I am here. There's not a problem. I'm not sick. This is normal. The contemplation stage where they're thinking, maybe I want to make a change, but they're not ready to do something about it yet. And then the preparation stage where they're starting to prepare and plan for change. The action stage, that's what we see a lot of while patients are inpatient, is that they are doing something different. They're eating their meal plans, they're not acting on behaviors. Then the maintenance phase, and that is that what we want, that is the main goal, is that people are able to do something different and then keep going, that the changes that they've made become part of their life. There's a really interesting article that I read as I was researching this topic, and I put it in the references if you want to read more about it. So it's assessing, is the trans-theoretical model enough? Is that a good predictor for whether someone will be able to change? This particular article said, yes, it is a robust predictor, but if you don't have confidence, then maybe it's not as accurate as we think it is. So you go back to the stages of change, so that action stage, if you're doing something different, but maybe you don't believe that you can continue to do that, especially when you go home, then the trans-theoretical model is not going to be a very good predictor of whether someone's going to continue to do new behavior. Whoops. So it also, if an individual has a high level of confidence, they're more likely to persevere through challenges and feel optimistic even after a failure. So that's really important. Confidence, I think, can be bolstered as you're doing lots of exposures and giving people opportunity to practice. So that's something to keep in mind. I put this in as well. This is the Precursors Model of Change by Fred Hanna. He actually has a book about this. But I put in this scale as a tool that maybe you could use with your clients to assess whether they are going to be able to make lasting, meaningful change. So it has these 7 different markers that you're looking at. So a sense of necessity, do they really have that urgency that they need to make a change? Are they ready for the anxiety that comes with making changes? Do they have an awareness of the problem? Can they identify thoughts and feelings? Are they able to confront the problem? How much effort are they putting into making a change? How hopeful are they about their future and their ability to cope? And then what does their social support look like? Of these 7 markers, the one that shows most if they're going to be able to make lasting change is that number 2, ready for anxiety. Unfortunately, that is something that this population really struggles with, is being able to tolerate uncomfortable feelings, especially anxiety. And so we see a lot of avoidance with this population. So that of this list is one thing that we really have to make a priority in working with clients so that we can make sure that they're ready for meaningful change. Okay, so now getting into the bulk and the really fun part of this presentation. So these are, through my research, I found 5 keys for maintaining change. So they've done all this, these clients have done all this work in inpatient care. Their families say, wow, it's like I have my daughter back. I haven't seen you in a long time. But are they able to maintain that change at home? So these are the 5 keys that will help them to do that. Motivation, environment, skills, habits, and resources. Okay, motivation. I think this is something that we're really familiar with as providers, but I'm going to flesh it out and talk about what kind of motivation is helpful for change and what kind of motivation is helpful for maintaining change. So there's these 2 kinds of motivation. Extrinsic motivation, that means that you're motivated to perform an activity to earn a reward or to avoid a punishment. And then there's intrinsic motivation. That's motivation to perform an activity for its own sake and for personal rewards. I thought that was a cute little picture to illustrate that. So extrinsic motivation, I like to think of as your morning cup of espresso. So it gives you that boost, it gets you going, it gets things started. But just like caffeine, for me, starts to fizzle off around lunchtime, and then I've hit that slump again, so does extrinsic motivation. So it gets you going, but it's not going to motivate long-term change. I think, though, it is helpful to incorporate as you're working with clients, because sometimes people are stuck and aren't able to make that initial change. So extrinsic motivators, these are some that we use inpatient treatment. It can look very different outpatient as well. So maybe wanting to get out of treatment. I think that's the #1 motivator for clients that I see, is they just want to get home. So they're going to do whatever they need to do to get home. Wanting to go back to school, wanting to go back to family, wanting to achieve certain level of treatment, to get more privileges, getting off of a wheelchair. That's one that I hear a lot. If someone will be like, I'm going to eat because I don't want to be pushed around in a wheelchair all day, or getting to start physical activity like yoga. I really like to talk about intrinsic motivation with the support system, so that they are applying things at home, even in their discharge contracts that line out, if you don't eat, then this will happen, so that there's this really immediate either consequence or reward that happens based on what a client is going to do. What was I going to say? So with extrinsic motivation, I also want to say that what I find in this population is that punishments or consequences tend to be more motivating instead of rewards. I have had clients who have come in and their parents have been paying them if they'll eat their food. Doesn't seem to be very helpful. It doesn't really help them to do something different. I even had one client whose family told her, hey, if you'll just get better, we'll buy you an island. And this was a very affluent family. They really would buy her an island. Unfortunately, as I hear back just through the grapevine, this patient is still struggling. So even buying somebody an island isn't motivating enough to get them to make some changes. What I see instead is that as families really hold boundaries or take something away, that this population, their brain tends to be a little bit more sensitive and responsive to that. I'll give you an example from a family session that happened just a couple weeks ago. So I was working with a client and her family had just come to town to start this transition home. Well, she was mad at her family and hated family sessions. So we get into family session and she decides to not talk. That's always my favorite sessions. It's terrible. It's very awkward. So her family starts to feel that tension and discomfort of her not talking. And so they start to offer her different rewards. And they say, oh, sweetie, we bought you a new iPad. We brought it with us. We'll help you set it up tonight. We brought you your cell phone. Let's get online and do some online shopping once we get back to the hotel. Not helpful, didn't help her to budge at all. So instead, I said to her, hey, at this point, you're wasting my time and you're wasting your family's. We're going to reschedule this session for tomorrow. And by the way, in the meantime, I'm dropping your level because you're not participating in your treatment. So you're not going to have as many privileges. But tomorrow, if you engage in family session, I'd be happy to put you back on the intermediate level. Well, by golly, at first she was like, no, I'm still not going to talk to my family tomorrow. But this girl came to session with a list of things that she wanted to talk about in family session and indeed did engage for the entire family session the next day. So holding that line, having some kind of consequence is really helpful. Intrinsic motivation. So intrinsic motivation incorporates your values, pleasure, and identity. Clients are more likely to sustain change when it aligns with who they really are and what's important to them. In college, it is no secret that I hate math. That's probably some of the reason why I like to work with people. I don't like numbers. They are scary. But in college, I had to make it through my math class. Well, I would not have been motivated to do all of that math homework had it not been for the cute boy who was also in my math class and who I later ended up marrying. But because I wanted to spend time with him, because it was pleasurable, I did a lot of math homework that semester and passed my math class, thank goodness. The best example I can think of intrinsic motivation is my sweet grandma, who I really look up to. So she is a lady that takes challenges in stride. My mom, when my mom was 12 years old, her dad passed away. And so here my grandma is left with 2 children. Her husband passed away very suddenly and unexpectedly. And she grieved for a time. She was really devastated, as you would expect. But then she came to the decision that she is the kind of person to choose joy, even in really challenging situations. And as I've seen her carry that value through her life looks really different than other people her age who didn't have that value, and she makes choices that are different than other people would. I love this quote from a book called Atomic Habits. I also referenced it in the resources. It says, every action you take is a vote for the type of person you wish to become. No single instance will transform your beliefs, but as votes build up, so does the evidence of your new identity. Intrinsic motivation does take more time to develop. So that extrinsic thing can be very immediate. Intrinsic motivation, I find, sometimes doesn't even happen during inpatient treatment. So with clients who have been engaged in the illness for such a long time, they don't even know who they are or what they care about anymore outside of the eating disorder. Even treatment itself can be so eating, just everything revolves around the illness and trying to get better. So I find that this intrinsic work of finding out who they are, what is meaningful to them, finding pleasure, that happens in outpatient care. Sometimes even with my clients, I like to write out things for them to try when they go home as they're learning who they are. So maybe I encourage them, hey, you really are so creative. Why not take some art classes? Or why don't you try out for a play? And so we're outlining different things that they can do to really figure out who they are. Okay, application. So here's some ideas that you all could use with your clients. Assisting clients and their support systems with outlining extrinsic motivators, just like I talked about, maybe even in discharge contracts or as some kind of behavioral contract that you do at home. Providing journal prompts and worksheets for clients to explore their personal values. I really like to do this in a group, in that relapse prevention group that I talked about. I print out a huge list of different values, fold them up, cut them out, fold them up, and then put them in a hat. And so we go around the room and each girl will draw out a value like honesty. And they have to outline how the eating disorder got in the way of living by that value. So maybe how they were dishonest in the illness, and then talk about why that value might be meaningful for them. 100 beads, that's something that I do personally. It's kind of a nerdy thing that I like to do. So on my windowsill in my kitchen, I have 2 different jars and 100 beads. So I choose a challenge, and then I'm moving beads over every time I feel like I'm doing that challenge. And I'll give you an example. So a couple of months ago, I was working on this challenge of taking more risks. I wanted to be the kind of person that took risks. And so I was doing lots of different things, having challenging conversations, putting myself out there. And so then when I'm sitting in a meeting here at work and the director said, who wants to sign up to do a webinar? I raised my hand because I'm the kind of person that takes risks. And because when I went home, I got to move a bead over to the other jar to show that I'm the kind of person to take a risk. And that, ladies and gentlemen, is what brings you this webinar today, is that a couple months ago, I took a risk, I moved a bead because I'm the kind of person to take risks. Also discussing with your clients what new hobbies and interests they may want to try to develop their own personal identity. Environment. So a supportive recovery environment begins with one's inner circle. So that's their family, their friends, those people that are closest to them. Having loved ones who are supportive can help to provide a buffer from diet culture and comments that are made outside of the home. So if your family and friends are being supportive, the stuff that goes on outside of the home isn't going to hurt as much or be as impactful. I do a lot of family work with my clients, and I see a lot of progress and really incredible things happen within that support system. I also see some things that are really sad. So I had a client several months ago who was very focused on mom throughout her treatment. Her mom was a pretty restrictive eater herself, though she did not have an official diagnosis of having an eating disorder. And so this client was starting to do virtual meals and snacks with this mom, and the mom may eat, she may not. So this particular day, the client was having a donut for breakfast. Well, she was terrified of donuts, and it was a really big challenge for her. So she said to her mom, "Hey, this is really scary. Would you eat a donut with me?" And her mom said no. So we get to family session later that day and are talking about this situation that happened where her mom didn't eat a donut with her. And her mom's comment to her and myself was, "If it was a life or death situation, I would eat a donut, but otherwise I'm not going to." Which the irony of that statement, as her daughter is in a hospital for an eating disorder, which is a life or death situation, it's just really sad. So sometimes families are not able to get on board and be supportive. So if that's the case, you're really looking at who outside of the family can be and provide that support. So of course, we're all aware of diet culture. Messages from diet culture are everywhere. What we can do with our clients is we can role model how they can engage with diet culture messages instead of just ignoring them, because that would be impossible. I had my mom when I was growing up. She is a teacher and everything is a teaching opportunity. And so when we would watch movies at home, I hated this, but she would sit there and talk about, well, is that really true, as we're watching the movie? What kind of worldview do you think that this movie is coming from? And she'd be really engaging with the content. I still hate watching movies with my mom for that reason, but even if she's not there, in the back of my mind, I can hear those questions because she was engaging so much with the content. So that's the way that I think now. Then there's environmental triggers, when sometimes something really simple can help make such a big difference. One of my clients right now, her bedroom is in the back of the house, and she also has a bathroom that's connected to her bedroom. And so that is where she goes if she's going to purge after a meal. It was as simple as telling her family to lock her bathroom door, and just that provided enough barrier for her to give her space to make a different choice. So things you can do are removing scales, donating clothes that no longer fit, deleting triggering images, following people on social media with positive recovery messages. So here's the application portion. So prior to leaving treatment, having clients identify what environmental cues need to be removed from their home before discharge. So that's the things I just talked about, like scales, clothes that don't fit. During a session, have a client do some spring cleaning on their phone. I have started doing this more and more, and it's rare now that I even have a client discharge before we do this. So we have them bring their phone into session. They go ahead and delete the diet apps and anything that's diet related on their phone. They go through and delete triggering images of themselves that they had taken when they were at a low body weight, and then unfollowing people who don't promote recovery. Assisting clients to write letters to the people in their support system, thanking them for their support and outlining specific ways that they can offer support moving forward. Skills. Does anybody else have a drawer at home that they stash gift cards? I have got a whole drawer and there's all these random miscellaneous gift cards in there that have remaining balances that I may or may not ever use. I think that gift cards are an excellent example of coping skills. You have them, they're in your pocket, you can use them anytime and reap the benefit from them, but they only benefit you if you use them. I love this phrase, practice doesn't make perfect, practice makes permanent. Our clients can get really focused on things being perfect and doing things the right way. That's really not the goal of using a coping skill. It's to do it over and over and over again. So just like a muscle, it gets stronger, and it's reshifting the way that your brain responds to anxiety and to triggers. Skills can include, and I'm sure you have some coming to your mind without me even mentioning them, expressing emotions, being assertive, saying no, asking for help, deep breathing, and grounding activities. I had one client who would get so nervous coming into session with me that she would actually throw up. So it was lovely. Every time I'd pull her for a session, I knew what was coming. The trash can was ready. She'd walk in my office and she would throw up. But then after that, we'd bag it up, clean it up, come back down to my office, and we would practice these skills. So even every single time there's that consistency of, okay, we're practicing deep breathing. These are the things that we're doing. So she was still getting that practice, even though she was really anxious. Utilizing skills of regular reflection can help to transform slips into opportunities to grow. That's something that I think that the outpatient team or whoever the team is can really help with, is helping patients reflect or clients reflect and learn from mistakes or slips. There are some things that we do in inpatient care that are just ideas that you may want to put in your own practice. So every morning at breakfast, the patients go around and they set a goal for themselves for the day. It has to be therapeutic and it has to be measurable. So saying have a good day, that doesn't cut it. An appropriate goal would be maybe talk to my therapist today about the phone call I had with my parents last night. So that's both therapeutic and measurable. We then review the goals at night, and the girls go around at snack and say whether they accomplished their goal or not. Super simple, easy to do, but helps them to reflect. You could have your clients practice saying highs and lows of the day. You could do what I do. So risks obviously are something I'm really working on in my life. And I have a daughter who does not like to take risks. She is really pretty turtley and doesn't like to do new things. So every Friday night, it's pizza night at my house. It's so fun. We always look forward to it. And during dinner time, we go around the table and we each say a time that we took a risk that week. So that's very specifically looking for something that you did that week that helped you to take a step forward. Incorporating meditation, journaling, or practicing gratitude. So here's some application that you all can use, engaging the support system in practicing skills. I like to have my clients write out the coping skills that they've been practicing for their families to see. That way the families can help remind them at home. If they say, hey honey, you seem like you're really anxious, how about we do some grounding skills? How about we practice some deep breathing, whatever it is. Practicing coping skills during sessions. Sometimes clients just aren't going to do it on their own. And so every time you might start a session with a coping skill so that they're getting in that practice and becoming more comfortable with it. And then using habit stacking. Habit stacking is something I'll be talking about in a couple of slides. So just keep this as a little reminder. Practicing habit stacking to incorporate skills into daily routine. Okay, habits. So habits increase our freedom because they declutter the conscious thought. They also don't take any willpower. So if you have a routine, you don't have to think about what time do I wake up? What time do I make my coffee? Did I brush my teeth today? Those things are all things that you're doing every day at the same time. They're super predictable. Habits that maintain recovery could include attending regular outpatient appointments, getting a good night's sleep, meal planning, routine meal times. Okay, so here it is, habit stacking. Habit stacking is linking new behaviors to already established ones. So that could be like brushing your teeth, making your bed, brewing coffee, or turning out the lights. So an example of this would be, while my coffee is brewing, I will plan my meals for the day. Every Tuesday after class, I will drive to my outpatient appointments. After brushing my teeth, I will think of something I'm grateful for. So it's using those things that you already do that are really familiar to you, and then adding in something new that's going to really help to promote recovery. I love this term as well, keystone habits. So keystone habits are a small action that leads to a cascade of other actions. I can tell you one of mine. So one of my keystone habits is flossing my teeth. I hate flossing my teeth. It hurts. Who wants to do that? But I do floss my teeth every single day because it leads to so many other things that are helpful for me. If I floss my teeth, I brush my teeth. Because why would I floss my teeth and then not just go ahead and pick up my toothbrush and brush my teeth? If I brush my teeth, I always wash my face. If I wash my face, I always put on my favorite face moisturizer. It's one of my favorite times of the day. I love it. It smells so good. If I'm doing all of these things, I'm standing next to my husband who is also brushing his teeth, and we're connecting about our days. So that helps us to have a good relationship. Sometimes that's after getting kids to bed, sometimes that's the time that we have together is brushing our teeth and doing this. So that one small action of flossing my teeth, it leads to many other actions, and that's how I have a really good marriage. It's just that simple. Many find that they lack the willpower to continue recovery lifestyle, but helping clients to apply one keystone habit can create this domino effect that impacts everything else. I think that this can be especially applicable for dietitians, that dietitians are helping clients with some different food habits like meal planning, because something really simple like having a meal plan for the week can just take away one of those excuses when they get down to the meal and say, oh, I don't know what I'm going to eat today. Okay, so here are a couple of applications, helping clients to list several of their established habits. Next, assist them to create a list of habits that would support their recovery, and then you're linking those together. I think it's helpful to start small, so maybe just add in one new habit and really focus on that. Then also helping them to identify what one habit cascades and continues other recovery habits. Okay, resources. So when I first started doing research and I came down to resources as being helpful to maintain change, I actually didn't even want to write about it. I didn't want to think about it because it kind of made me sad. What happened for me was I started to think about all of the lack of resources that some of our clients have. Sometimes they don't have a family that's supportive. Sometimes they don't have access to an outpatient team because they live in rural Oklahoma. Sometimes they don't have the finances to be able to pay for all of these outpatient appointments. So I really started to get down. What I have come to and what I've realized is that instead of looking at things and saying, I don't have enough or this client doesn't have enough, sometimes the tiniest thing is valuable in moving them forward. So resources are anything available to you, both inside and out. It could include time, energy, social support, or even someone's unique giftedness. I have a client right now who her family is just not supportive. They're not on board with her recovery. And so every time I meet with her, I remind her, hey, you're someone who has really good social skills. People like you, your teachers love you, and you have like 50 friends. You can get your needs met in other places. So I'm speaking that into her. I'm reminding her of that regularly, of what her resources are. I feel like there was something else I wanted to say about resources. Oh, I wanted to give some examples. I have two stories that kind of surprised me. About a year ago, I had this client who was determined to not get better. She made it very clear that she was going to go home and relapse. She did not. She was like, I'm going to go through the motions. I am not doing this. I will not get better. So I did everything I could. I did some motivational interviewing. We worked on skills. We tried to talk about things. And I really hoped that I'd see a shift for her before she left. I didn't. She went home. She did relapse. I was quite shocked and surprised when a year later, I received an email from her asking if we could connect. And when we got on the phone together, she shared with me that she was in recovery. She was in her weight range. She had an outpatient team that she was connected to. And of all of the wonderful things that I tried to provide for her, none of that stuff had helped her. What it was for her was she got a dog. Of all things, that dog and that connection that she had with it was what helped her to move forward. I had this other client who was also here and super stuck. What was different for her though was that she really, really wanted to get better. But every time we went to the dining hall, she would hide food. She would have really good intentions. We'd talk about it before, and then she'd get so anxious in the dining hall that there would go her butter into her pocket or whatever it was, even a piece of cereal. It was always something. Well, I was just banging my head. I didn't know how to help her move forward. But one of our very charming and brilliant dietitians knew that this patient liked anime and bought her stickers, of all things that teenagers are motivated by. So these were really cute anime puffy stickers, and they together created a chart, and every meal that the patient ate and didn't hide food, she got a sticker, and she really liked it. She liked the way they looked. So by golly, she moved forward. She had day after day of eating 100%, of not acting on behaviors and hiding food. And that patient is still in recovery today. I think that was the turning point for her, with something so simple like having stickers. So anything clients can use to move forward. They are so resilient. I do like to point out too that fatigue, stress, intoxication, those all can limit your ability to access your personal resources. So really helping clients to prioritize self-care helps to ensure that they're accessing their resources all the time. Okay, oops. So I have a clip I want to show. It is from the movie Apollo 13. If you guys have watched that movie or are familiar with that story, this was the third mission to land on the moon. And what happened was, instead of reaching the moon, the rocket ship, there was an explosion within the rocket ship and an oxygen tank exploded. So then they weren't able to breathe oxygen. There was too much carbon dioxide, and there they are trapped orbiting the moon, can't breathe. They didn't think that they'd be able to make it back to Earth. So what happened was their at-home team had to give them direction on what to do, and they were only able to use to make this repair so that the astronauts could breathe. They were only able to use what was inside of the rocket ship, which was a whole pile of super random stuff. So I have a clip that I want to show. Lauren, will you help me? And there might be a little bit of a lag, but you guys will get the gist of the content. Cool. Awesome. Yep. Awesome. Oh, we might have to watch an ad. All right, bear with us while there's an ad. That's life. Oh, here we go. Skip ads. Do I need to turn it up?
We have a solution for carbon dioxide. Filter foam and a 5 filters and a limb, which are meant for you guys for a day and a half. So I told the doctor they're already up to 8 gauges. Anything over 15.
Oops, sorry.
Their judgment back out the beginnings of brain asphyxia. The scrubbers on the bench, it takes away crutches. The ones on the limb are round. This isn't a government operation. This isn't a contingency we remotely looked at. Those CO2 levels are going to be getting toxic. Well, it's just government, then we're pegging around. Okay, people, listen up. Go upstairs. This one, we got to come through. We got to find a way to make this fit into the hole for this. Using nothing but that. Let's get it organized. Okay, let's build a filter. Yes, it's liquid poison. Heads up, people. Look out now. What's this? That's what they got to make. Well.
Okay, so I'm going to go ahead and pause it there, but you get the gist of it, that they were able to use what the astronauts had in their rocket ship to create something that saved their life. I love this clip because I feel it's so applicable to this population. Here they are way out in space. All they need to do is to get back home to who they are and to the people that love them. And so how do they get there? All they have is what's inside their rocket ship. You can't change their environment. You can't change their education. What they have is what they are going to have to use in order to get to recovery. But what I've seen over and over again is sometimes the smallest thing is enough. Sometimes the smallest thing helps them to make a shift. Oops, went a little fast. So here's the resources application, helping clients to create a list of their unique resources. These clients can suffer from low self-esteem, and they may not be very outspoken about what their resources are or what their gifts are. So you may have to speak that into their life or even ask loved ones around them to help to add perspective. You can also help them have them journal about what environment helps them to best utilize their resources and what would limit their ability to access the resources. So I think do we have time for questions? Okay, so we have time for some questions. And so what do they do? Do they comment?
You can just comment in the chat box.
Okay, so you can comment in the chat box if you have questions. And I'll just keep looking. If you don't have questions, I have included my contact information. This is an area that I'm still learning and growing in. If you have ideas that you want to pass on to me, or if you have questions for me, I'd be happy to address that, and we could connect further. Okay, so I'm being prompted to say you've got about 30 more seconds. If you have any questions, I'd be happy to answer that. And then otherwise, if you think of something later on, if you wanted for me to clarify, I would be happy to do that. I also wanted to say that I did write an article that corresponded with this material, and it was written for you as the provider to just hand to your client. So if you'd like for me to send that to you, I'd be happy to do that. It includes all of those 5 keys that we covered today, and then it also includes an application for a journal prompt that your client can use to go ahead and engage in the material. Do you have anything that you want to do to wrap up, Ms. Lauren? Okay, well, I thank you guys so much for joining. And I really appreciate you spending your time with us. Please let us know if we can support you all or if there's any resources that we can provide for you moving forward.
Awesome. And it looks like Miss Heather put the link to that article on the chat box. And also, in addition, I can send it whenever we send the surveys and the certificates. Thank you guys so much. We appreciate you joining us.